My name's Dr. Rob. I'm a chiropractor. If you haven't met me before, chiropractic is generally considered to be a therapy that deals with the spine and the nervous system, but we also do approach joints as well, other joints of the body, including the knee. Our training is very similar to a medical doctor in many ways, with a large emphasis on orthopedics. We don't do a lot on pharmacology. We're trained radiologists as well, and we treat patients using only natural ways, so a hands-on approach. So we don't use any surgical techniques or any pharmacological interventions. If you've not heard of chiropractic before, then have a Google and try and learn a bit more about it. So what we will cover today is what is this condition, the osteoarthritis, what it entails, what are the risk factors for getting it, the therapeutic movements that we can think about, and there's a lot to think about around that. So today we will cover some of the basics, a starting point for you to think about. I won't be able to cover every single aspect of rehabilitating someone with knee osteoarthritis, but I'll give you lots of food for thought. And we'll also think about movements that are either contraindicated or particularly risky, or movements that we need to build up towards, that we should avoid in the early stages. Can everyone hear me okay? Yeah.
Yes, we can.
Yes,
We can. Okay. Okay, everyone's good. So let's give you a little bit of background. Osteoarthritis of the knee or of the hip or the spine or any joint is essentially a degenerative condition. And it's characterized by the loss of hyaline cartilage. So around every surface of the bones of the joint, there is this articular cartilage, okay, which protects the joint. It allows smoother movement. It ensures that the detrimental forces of movement and shock and load, such as jumping and running, are dissipated away from the bones. And that means that the joint can be much longer lasting. Okay, so the characteristic really of osteoarthritis is this cartilage loss, hyaline cartilage, and it's something that we'll look at a little bit more as we move through. There are other changes associated with knee osteoarthritis, and again, I'll touch upon those, but that's the characteristic or the main characteristic. The risk factors are advancing age. So I hate to break this to you, but we are getting older. And as we get older, our bodies start falling to pieces. We are essentially degenerating. Of course, there's lots of things that we can do to prevent that and slow that down. But unfortunately, no one's figured out a way to completely stop it. Okay, so the better food that we eat, the better we look after our bodies through perhaps yoga therapy, asana, pranayama, meditation, controlling stress, ensuring that there's less toxins coming in from the environment, then we can minimize the way that we are degenerating. Okay, but essentially, researchers has said that by the time we reach around 80 years of age, around 50% of us will have knee osteoarthritis. Now, that doesn't mean to say that we'll be hobbling along and crippled at that age. It means there will be some level of degeneration. Okay, and that level of degeneration may not bother us at all. We may not even notice it. Okay, so don't become too concerned by that particular statistic. The other thing that is extremely common with knee osteoarthritis and a common trigger is trauma. So a history of trauma, some accident to the knee which damages associated tissues. It could be, for example, a ligament, so the anterior cruciate ligament, a ligament which is deep inside the knee, a ligament many of people have heard of because it's a very famous ligament. Many people or sports people will injure that ligament. When that's torn, what we start to get, for example, in the knee joint, rather than this smooth movement, we get this accessory motion, okay? Instability of the knee. And those surfaces of the joint can start to rub together and create a shear force and irritation, and that can break down the articular cartilage and lead to a degenerative process and osteoarthritis. So a history of a ligament strain or injury or tear or rupture. It could be a meniscus tear. I'll show you an image of the meniscus a little bit later, but there's another piece of cartilage. It's called a fibrocartilage, the meniscus within the knee joint. And that also helps to maintain stability, help dissipate forces and reduce shock into the knee. And when that's torn or injured, again, force is going to act into the bone and also break the articular cartilage down. Some people won't necessarily associate their osteoarthritis with a history of trauma. So sometimes it's a really minor injury that didn't necessarily create a big issue at the time. Maybe it was a small fall and maybe for 1 or 2 days it was irritated, but it creates a little bit of injury to a tissue such as the hyaline cartilage, and that starts a little slight cascade. And over a number of years, 15, 20, 30 years, it leads to the tissues breaking down even further. Okay, so history of trauma is often very significant. Now, obesity is also linked to it. Now, when I was in the clinic in Mysore, I had a chiropractic clinic there for a number of years. Just about every single patient I had come in would always say, not every single patient, but many patients would come in and say, if I lose weight, will it help me? Will it help my back pain, knee pain, hip pain? And logically, we will say yes. Because the less weight that you have in your body is the less you've got to carry around. It's more energy efficient for one, because you're not going to require so much energy to walk up to the shop and up the stairs and so on and so forth. But it also reduces a lot of pressure from the joints. And there's an excellent point there. For every 1 kilogram of weight loss, there's actually a 4 kilogram reduction in load exerted through the knee. So it's not like for like. So if you, for example, you're losing 10 kg, maybe you're 10 kg overweight, maybe you're more, maybe you're less, but that's equating to 40 kilograms less load through the knee. Now, for 5 minutes extra load, it's fine. But over a number of years, again, that's going to stress the knee out, okay, and potentially lead to issues. So when you think about managing osteoarthritis, if the individual is overweight, it can be quite a useful strategy to try and overcome some of the issues and prevent further deterioration of the joint, at least manage that deterioration, okay? And then there are genetics, certain genetic factors, some known, some not known. So it can run in families, for example. Sometimes the architecture of our joints is slightly different to another person. So essentially, we all have knee joints, but the shape of them, the way that the ligaments are configured, the way the meniscus is designed to be slightly different. And sometimes an individual, their surfaces of their bones won't fit so well together, and there can be slight instability. And again, that can create rubbing of the bones and breaking down of the joint. So let's look at the joint a little bit so you understand this, especially if you've not looked at the anatomy much before. This is a model of the knee. So we've got this bone underneath. This is your lower leg bone, the tibia. And then we have this bone through here, which is called the femur or the thigh bone. And then underneath this tendinous structure represented by this kind of orange plastic is another bone called the kneecap or patella. Okay, and I'll show you these in different ways in a moment. And then this blue structure is representing the meniscus. Okay, so we have this fibrocartilaginous structure between, and this acts like a cushion. And then on the surface of the bones through here, we have the hyaline cartilage. So we have two cartilaginous structures in the knee, okay? And both help protect it and reduce stress to it. So when we move that out of the way, if I just slide the kneecap out of the way, it reveals this groove. It's called the femoral trochlear. And again, you can see it's kind of shining surface. Again, this is articular cartilage, hyaline cartilage. Okay. And if we just bring that back and turn to the side, okay, you can see how the rounded shape of what's called the femoral condyles of the femur, how they sit on this structure here called the tibial plateau of the tibia. And then when we flex the knee, you can see that essentially different points. So you've got a different point contacting here. And when I go into flexion, you get a different point contacting here. So as we move, we're spreading load, we're moving across the surfaces of the joint, okay? Ignore how this is coming up. This is just the model not being particularly resilient. Normally the meniscus is attached to the tibial plateau. That won't move like that. So you can see these surfaces are articulating with each other, okay? So you can see how the femur and the tibia are working, but also now look at how the patella is sliding through this groove. So can you appreciate that as we go into flexion, the patella slides down and essentially back up. The patella doesn't really change position, it just changes its relationship to the femur. So when we think about osteoarthritis and also knee problems to some extent, sometimes it can affect just the patella and the femur, so the patellofemoral joint, or it can affect what we call the tibiofemoral joint, okay? So the tibia and the femur. And I'll show you that again on an X-ray in a second. So there's essentially 3 parts of the knee that can actually be injured. Here, okay, or the inside of the knee or the outside of the knee. In some cases of osteoarthritis, all 3 compartments, all 3 parts will be affected. In others, maybe just 1, in another, just 2. But generally, once one compartment is affected, it will start to have some detrimental effect on the others. I'll try and explain that a little bit more with an X-ray in a moment, so you can appreciate that a little bit better. So there's our knee, okay? We're looking at it from the top. There's the thigh, there's the femur, there's the tibia, and underneath there you can see the patella. Can't see the patella very well. You can just see it just outlined through here on the X-ray. It's a little bit hidden on this X-ray. And then we have the joint line. This joint is filled, as I said, with the meniscus and the hyaline cartilage. It looks like a gap, mostly because of the difference in density. So bone is hard. And so when we send the X-rays through, it passes through tissues differently, okay, and then changes the X-ray screen, and then we can obviously interpret the image. Because there's so much water content through here, it just looks like an empty space. But that's essentially filled with the meniscus all the way through there, through here, and then hyaline cartilage all through the surface, okay? Now, when we end in a situation with osteoarthritis, you can see how this surface starts to break down. So we're losing the articular cartilage. The space, the gap between the bones decreases. And with that loss of hyaline cartilage, as well as the meniscus will start to break down. There'll be tears and different changes to it. The bones come into closer contact. It also means that shock proofing that the cartilage provided is lost, and more stress is sent into the surface of the bone, particularly where the bones meet. So you can see, if, for example, if you look at the contour of the bone around here, and you can compare it here, can you see it's a bit more kind of irregular? And particularly if I show you through here, compared to here, can you just pick that out? There's some changes. There's extra bone being laid down. So there's osteophytes. So the bone cells are laying new bone tissue around the joint because it's being stressed in an abnormal way. That's the response of bone. So if we think about, for example, osteoporosis, which is a weakening of the bones. Not so much thinking about joints now, we think about the entire bone structure. When we think about osteoporosis, to try and strengthen bones, we want to create a stimulus to them. We want to move, exercise, send a beneficial stress into the bones. The bone cells then respond, lay new bone down, and our bones get stronger. Okay, there's much more to be said around osteoporosis than we've got time for today, but just a basic understanding. If we have a different situation, a pathological situation where we've got abnormal stress into the bone, we get the same response. The bone starts to respond. It's trying to make this joint stronger and more tolerant to this added stress. It will also be trying to, in many situations, stabilize the joint. This joint is less stable than this joint. And so if we add bone around the periphery in particular, it can sometimes help bring stability to it. Okay, so they're the kind of changes that you see. Sometimes you'll see, for example, how this inside of the knee, so this is the inner part of the knee, this is the outer part. You can see how the inner part is being affected, how the space is less when compared to here. Okay, so typically the most common compartment is what's called the medial compartment here is affected. And then you'll often see the lateral compartment also being affected and the patellofemoral compartment as well. And I'll show you an X-ray of that in a second. So today I'm going to explain. So this is just a little video I put together earlier. My wife was giving me some very strange looks earlier because I looked slightly crazed, and I was trying to figure out a way to describe articular cartilage to you, to make you understand its role and its function and its importance. And I was thinking, I was looking up into the stars, thinking or trying to get some inspiration. And I put these little videos together for you. So I'm just going to play them for you. They've got a bit of sound as well. So today I'm going to explain some of the roles of articular cartilage, also known as hyaline cartilage, within a synovial joint. So the plate here is representing one bone of the joint, and the bowl, the other bone. And you can appreciate if I move the bowl around, hear that noise. If I keep doing that, it's going to scratch the plate and the bowl. If I do that over many years, it's eventually going to lead to the bowl or plate completely breaking down. Also, if I compress and hit them together, it's going to create another larger force. And again, that's going to cause that to break down. But if I add in this sponge, which is representing hyaline cartilage, and also add in some turmeric water representing synovial fluid. Now, when I move, the surfaces of the bowl and plate are completely protected. So today I'm going to, so the bowl representing one bone and the plate representing the other bone are covered with hyaline cartilage represented by the sponge. And then the joint is lubricated with synovial fluid. Now, every time we load the joint, compress the joint, move the joint, the cartilage will deform slightly. The synovial fluid will be pushed around the joint. And as I remove that load, you can see the synovial fluid entering back into the hyaline cartilage. And that pumping effect is taking place every time you move. And that helps to lubricate the joint, also nourish the tissues, which rely on the synovial fluid for their nutrition, their oxygen, to maintain their health. So that's a really important point. So every time we move the joint, essentially we're pumping this fluid around. We're also asking the meniscus as well as the hyaline cartilage to deform, okay? And that gives it a certain stimulus. So it's been seen, for example, if you put the joint in a cast and you immobilize the joint for a period of time, the cartilage, the thickness of the cartilage will start to reduce because you're not stimulating it. The body doesn't maintain tissues if you're not really using them. If, however, you stimulate the joint in the right way, the hyaline cartilage can actually get thicker. So it's been seen in athletes, for example, the hyaline cartilage can get a little bit thicker. Hyaline cartilage, is really important to stress, is not very active. So within hyaline cartilage, within this tissue through here, there are cells called chondrocytes, okay? They help maintain the hyaline cartilage, but there's very few of them and they don't talk to each other. They're like little hermits, little hermit yogis, okay? They don't speak to each other. So if there is an injury or damage to the cartilage, their ability to repair it is very poor. Also, their ability to respond to stimulus to actually get bigger is actually poor as well. So for example, muscles, if you stimulate muscles, there's lots of myocytes, lots of cells, a really good blood supply. If you keep exercising that muscle, it will get bigger. Hyaline cartilage has the same property to get bigger, but it's fairly poor at it, okay? And usually not adequate to repair itself once it's injured. There are healing potential, don't get me wrong, but that's why we see this degeneration process taking place, because injury is not adequately repaired. This pumping effect, I want you to appreciate that every time we move, we're pushing that fluid around the joint, okay? That's lubricating the joint and nourishing the tissues. And this is where therapeutic movement has a potential benefit in helping the joint to settle down. If we can apply a low stimulus, a low pressure to the joint, a gentle stimulus that will nourish the tissues and help things to settle down. If we put too much stimulus, it will actually have a detrimental effect and cause the tissue to break down even further. So when we start working with this condition, we need to very carefully apply the dose, the correct dose of movement for that particular individual, and then gradually increase it to make the knee more functional again. We might not be able to change the hyaline cartilage much, okay, but we can improve a lot of things around it, including the muscles and other supportive tissues. We can also improve our mind-body connection, which I'll talk about in a moment. Now, in osteoarthritis, the hyaline cartilage is lost. It starts to break down and the quality of it deteriorates. And essentially what will happen is that the hyaline cartilage will become thinner. That will provide less protection to the joint surfaces. It will still provide some protection, but the joint will be less tolerant to movement. It means the joint can be irritated if the individual does too much. And we can get to a point where the cartilage is completely lost. And now we've got bone on bone. And that means that movement can become very painful, the joint very dysfunctional. Okay, so I hope that illustrates in a really simplistic way the role of hyaline cartilage and the importance of it, okay? And how it's involved in this degenerative condition, osteoarthritis. Let's have a quick look at the patellofemoral joint. This is what we call a sunrise view, okay, of the knee. So essentially we're looking at the top of the femur through here and the groove of the femur, the femoral trochlear. And again, you can see the space between the patella and the femur. This again is filled with hyaline cartilage, okay? And that allows that smooth, easy movement. In osteoarthritis, again, we lose or can lose this hyaline cartilage. And again, we get that bone-on-bone contact, okay? We can't often restore it like this. Most experts say that's completely impossible to restore, but we just try and improve everything else. And you can still get a great deal of function back into an individual's knees if you do the right things. Now, this is actually me massaging the patella, but I wanted you to appreciate something is that the patella is actually quite mobile. So if I can move it quite a lot from side to side, on my knee and in a fairly healthy knee. So essentially, we've got a width of the knee, the distance from one side to the other. If you divide that in two, you should be able to move the kneecap about 50% of its width to one side and 50% of its width to the other side. It should be quite mobile. And you can see if we look at the X-ray, how that's possible. I can move it across quite well from each side. With osteoarthritis, that will be lost. It becomes very, very stiff in there. And it's a simple test you can do on yourself if you have knee issues or you have knee osteoarthritis, or you get your students to do, or you can, if you're a manual therapist, you can actually test on your client, see how much the patella moves. If it's stuck and feeling quite stiff, it can indicate a problem with the joint, and it may indicate that this joint is starting to deteriorate and degenerate. But that joint should be nice and mobile. Now, I've basically said that once we've lost the hyaline cartilage, we can't really get it back. We can get it to settle down. We can stop irritation and it breaking down rapidly, and we may be able to get some healing effects, but we have limited capability to completely restore it. Okay, but you'll be amazed at the things that you can do by improving other tissues. So if you can improve the musculature of the muscles around the knee, okay, and get more those muscles more active, you can stabilize the joint, you can prevent a lot of the irritation, and the individual can be relieved from a great deal of pain. So over the years, I've seen, I have to say, some really, really bad looking knees, some knees that there's absolutely no cartilage in whatsoever. The knee can still move. Doctors were suggesting knee replacements, and just using some simple techniques, they got a lot of function back. So 60, 70% function back, 60, 70% reduction in their symptoms, even though the articular cartilage is lost. Okay, just by improving everything else. So just because there's loss of articular cartilage doesn't mean there's nothing that you can do. There's still so much you can do, and I'll try and give you those ideas as we move along further. So when we injure a knee, okay, there are a couple of different processes which take place to the muscles. The first one's called Arthrogenic muscle inhibition, or AMI. And this essentially happens or relates to the muscles becoming both weaker and smaller. Okay, and it can happen from a knee injury, it can happen with knee surgery, it can happen with osteoarthritis as well, or other types of osteoarthritis, or sorry, other types of arthritis. And it's partly due to neural inhibition. So neural inhibition, or neural drive, should we say, is essentially how much the brain speaks to a muscle, okay, how much they communicate together. As you know, if you just lie down in Vajrasana, which is a great yoga posture, don't get me wrong, but if you just lie down there for the next 2 years, for whatever reason, but you might want to, say you do that, your muscles will get smaller. They will start to shrink because your brain is not speaking to the muscles so much. The muscles are not being used, and they start to atrophy. When you injure a joint, it could be the spine, it could be the hip, it could be the knee, the hand, wrist, wherever, the muscles and brain don't communicate as much, and the muscles start to become smaller. Now, the problem with that is we lose strength around the joint. The joint is less stable. We have less control over it, and the joint is irritated even further. Okay. And so therefore, trying to get these muscles to wake back up, trying to restore some communication between brain and muscle is really, really important. The other thing that can take place is something called arthrogenic muscle response, or AMR. And this is similar, but slightly different as well. So what can happen in this situation is we have a reflex reaction of muscles around the joint again after injury. But in this particular response, muscles are inhibited or facilitated. So some muscles can work less, but other muscles can work more. So for example, around the ankle with chronic instability, if the ankle is really, really loose, for example, over a long period of time, what's been seen is that the quadriceps have greater facilitation, they work harder, whilst the hamstrings are inhibited, they work less, okay? And that inhibition can be seen on both sides. So on both sides for the individual, even though, for example, the right ankle is the problem, the hamstrings on the right will be weak and the left. And so that's a really important point when it comes to dealing with knee osteoarthritis or any bilateral joint. So for example, a hip or a shoulder, you always want to do some therapy on both sides. You probably want to do more on the affected side, but creating some stimulus on the other side can be very important because often there's an imbalance even on what's considered the healthy side. Okay. Now you get this muscle change, both the AMI and AMR, and as long as the injury is there, as long as swelling is there, then that is in place. As soon as you get swelling down, okay, so for example, if you just recently tore a ligament or you tore the meniscus, the swelling increases, okay? Whilst that swelling is there, there's the inhibition or the AMI. As the swelling comes down, okay, then that AMI will be reduced. Okay, it will start to return to a normal kind of function. And they've seen that experimentally. So for example, they've injected saline or a salty fluid into the joint to mimic swelling. They've recorded that the muscle now is weaker, it's not contracting as strongly. They aspirate, they remove that fluid, and the strength returns. Now, in osteoarthritis, you've got this often a constant irritation. So to some extent, you've got this constant loop that the joint is not allowing, and the brain is not allowing those muscles to get their full strength. And it means that it's very important often to maintain a constant stimulus. So an individual, in my opinion, with osteoarthritis of the knee needs to do a little often. So a little bit of movement to stimulate those muscles, to get them stronger, to keep trying to maintain that communication, but not too much that it irritates the joint, okay? So for any person that's watching today or any student that you may have with a long-standing issue, sometimes it's difficult to completely remove the issue. It becomes a management. You have to manage the issue, and often you can manage it so well, it doesn't bother you on a day-to-day basis. With osteoarthritis, it's definitely most commonly a condition that you need to give a little bit of care to each day, whether that be a little bit of movement, whether it be oiling, getting some oil around the joint, which can be extremely beneficial. But you've got to do something very often. Let's think about a little bit of therapeutic movement. And we'll really just look at the initial phase, and I'll give you the rationale of why we approach it this way, and also a few ideas on how to progress things. So most importantly, if someone comes to you initially with osteoarthritis and they're in discomfort, it's bothering them on a regular basis, you've got to, first of all, let things settle down. You've got to try and minimize the stress and strain to those tissues to allow things to kind of calm down, okay? The irritation to stop. And once it's stopped, you've got a better chance to start stimulating those muscles, stimulating the joint, and getting an improvement. So in the early stages, you really need to minimize strain. If the individual is playing sports or doing a lot of yoga or running or whatever it might be, if you can have that chat to them, express them the need that just let's pull back in the early stages, okay? Rest things, keep moving, doing a little bit, but not overstraining. And then as we get you stronger, as we get your lower limb, the entire lower limb more functional and stronger, then we can think about doing more of the activities that you've been doing and want to do. So in the ideal situation, we get the individual back to doing the activities that they love doing. Not always possible, but in many cases it is. Okay, but in the early stages, you've got to get things to settle down, and you need to minimize strain. The approach that I've always followed is to stimulate the joint without moving it. So you saw earlier, for example, with the sponge, when I compress the joint, if I load the joint, I can actually create this pumping effect. And that pumping effect will distribute fluids around the joint, nourishing fluids that will maintain the health of the tissue. It will also help to pump the waste products of cellular metabolism. So carbon dioxide, for example, it helps get rid of that out of the joint, which can be detrimental. But because you're not moving it, you're not overly stressing it, you're not loading the joint too much. So even, for example, and I'll show you in a moment, even a simple contraction of the quadriceps or the muscles around the leg, but the knee stays still, can still increase the load gently. If, for example, I do a squat or a lunge movement, we've got a large amount of movement, we've got high compressive load, that will irritate the joint quite easily. So stimulate it in the smallest possible way, and then over a period of time, build up that stimulus, more load, and then over a period of time, more movement, but in a very gradual fashion and in a very careful fashion, because if we do too much, again, we'll irritate it. So with each individual, you need to try and figure out how much they can do now, and also where they want to go to, and how those steps and they get you from essentially A to B. You need to consider the entire lower limb, okay? The hip will be affected, the ankle will be affected. You may see changes to the foot. There will probably be changes to the pelvis. Sometimes it may be that the hip issue has caused the knee issue, or a spine issue has caused the knee issue. So don't just focus on the knee, look everywhere. It's really important that you start often by looking at the knee and see what's going on there, and then expand your vision outwards and try and understand which other areas you can improve. Because, for example, if you can improve strength around the hip, you can relieve a lot of stress or detrimental stress, potentially referring down to the knee. And then once you're settled, you need to really think about adding in movements which stimulate the whole lower leg. So in a moment, I'm going to show you some movements, first of all, which are mostly going to stimulate the muscles and the knee joint. But once you've got that preliminary kind of foundation, you need to think about how you're going to stimulate the foot and the ankle and the hip as well, because that entire lower limb is working together. You can't just think about the knee. You need to think about everything in its entirety. And you need to start to think about, at some point, how you're going to make that individual more functional. So if this individual, as we've seen, has changes to the muscles, okay, they won't have as good control over the knee as they should, okay? Every time that they move, for example, to get in or out of a chair, they are potentially going to irritate their knee, okay? They'll irritate the knee to some extent because the cartilage is lost and the load may be too much. But if that knee doesn't move in quite the right way as it should, then there's potential risk of more irritation. So you need to think about the movements that they need to make. So getting in and out of a chair is a classic example, or getting up and down from the floor. How can they make that movement with minimal stress to the knee joint? And this is not something you necessarily start with, but it's something you need to work towards, because on a daily basis, you need to minimize irritation to the joint. And the only way you're going to minimize that is to make sure that the joint is working properly and is controlled fully. Now, so this is a really simple place to start with therapy. And this is really just your pumping effect. So we're just doing a quadriceps isometric contractions. The muscle is shortening, it's contracting, but the joint isn't moving. There's no movement in the joint. And as I said, that will create a pumping effect as I contract and then as I relax. So as I contract, the So contract, the pressure increases in the joint. And as I relax, the pressure decreases. And that can be a great way to create a bit of stimulation, turn things over around the fluids around the joint, as I said, and get this muscle working a little bit better, repeating that a number of times. Essentially, when we think about the effects of asana on a very simplistic level, we're trying to move energy from one place to another. And the way that we do that is by changing pressure. If we create high pressure here, it's going to force something out to this lower pressure. If I then increase pressure here, but decrease it here, the reverse is going to happen. And that's how we can move energy and prana through the body. A very simple place to start. And most knees can tolerate it. You might sometimes need to be a bit careful that the individual doesn't jam the knee back, force the knee back towards the floor or the bed, wherever they're practicing. You can sometimes put a cushion under there to prevent them. Also make sure or advise them not to allow the heel to raise up as they do it. Okay, so make sure the knee stays neutral. It doesn't start to extend too much or hyperextend. Then a good place to move towards is this, just a simple leg raise. Now, again, the joint isn't essentially moving. It's moving through space, but there's no flexion or extension. This is asking the hip to work, it's asking the muscles around the leg to work, and it will start to build stability and a greater stimulus. Very safe movement for the knee. It's not always safe for someone with a low back issue, though. So if the individual has a low back issue, I tend to avoid this and move towards different alternatives. Okay, but this simple movement can go a long way to helping the individual. And over the years, especially during times when I was moving around from place to place, and I wouldn't necessarily see patients over long periods of time, often I would give them that first exercise, this one, and this movement with the leg rolled out and raising. So exactly the same movement as before, but with the leg turned out. So just 3 exercises. And the feedback I got in terms of the improvements was really good. They hardly did anything. I just got them to do those simple movements and oiling the knees, lots of oil around the thigh, massaging the muscles around the joint. And often they were saying they were 50 or 60% better just by these simple movements. Very, very safe for the knee. You can also lie in the back, and this will
lift it up or bend.
This will stimulate the back of the legs, the hamstrings a bit more, and the gluteals. Just raising the leg up just a little bit. Now, again, you've got to be a bit careful with a low back issue. If the back starts to, or the spine starts to extend, okay, it will irritate. It will irritate the joint. Sorry, I'm just going to mute Jyoti. It will irritate the back if you're not careful. Okay, so a low back issue, you want to be a little bit careful of that one. There is a variation of this where you keep the thigh down, okay, and with the foot on the floor, just try and lift the foot up a little bit, but the knee stays down, okay? Just create a little bit of flexion in the knee, maybe around 4 or 5 degrees, just a tiny bit. That would really activate the back of the leg, especially the hamstrings around here, to help strengthen it. It can be quite a good way to get more tone around those muscles. So that, or those 3 movements create good tone. They don't necessarily give great control over the limb, okay? Which is the next important step. But this is an early stage kind of thing that we're looking at. Really good place to start. Now, what I do now is I'll show you a few movements that we can do together, and you can join me if you want to. What we want to think about, first of all, So samastitihi, yeah, is a really important place to start, okay? So maybe feet about hip width apart. Make sure that the weight is distributed really evenly through the feet. So often you'll find with someone with osteoarthritis, they tend to perhaps lean away from the affected side, or they may have some kind of asymmetry in the body, and teaching them to stand more in a balanced way can be really important. So really get the individual to think about where the weight is distributed. Is it too much towards the heels? Is it towards the front too much? Do they fit it on the outside of the foot on one side and the inside of the foot on the other? Really try and feel that symmetry, okay? And get to a balance point where you feel that the feet and how they're contacting the ground is nice and even and balanced, okay? We want the weight a little bit away from the heels, a little bit more towards the fronts, not all the way to the toes, okay? If you start to go more towards the front, as you might notice if you're doing this with me, the more you lean forward, the more your toes will start to grip. And if you see that on an individual, if they're standing and their toes are gripping, their weight is probably too far forward, okay? So just bring them back, they start to get that relaxation back in the toes. But getting them to understand samastiti can be really good. Really, in this position, have a good look from their sides of the individual and see where the knee is. Make sure there's no hyperextension or flexion. You may see in some individuals that the knee, on the knee issue side, the osteoarthritis, the knee is hyperextended, or you may conversely see it's slightly flexed. Sometimes with a very long history of osteoarthritis, you may actually see that they can't actually straighten the knee fully. It may actually be slightly bent. Don't try and force it back. Over time, it may improve a little bit, but it may be the way that the joint has responded to that long-standing stress that it can't straighten anymore. But look from both sides, okay? Right and left side, front and back, and see the alignment and see how you can perhaps guide them to better balance. And really, it's a great place to kind of start thinking about connecting back to the ground. There's so much we could talk about samastiti and the benefits, but just getting the individual still and connected back to the body is fantastic. From there, what you can do is create contraction of the muscles of the entire limb, again, to try and build up some greater tone. So I'll come forward a little bit so you can see perhaps a little bit better. So what we're going to do is we're going to go through a process where we try and contract muscles all the way from the hip down the leg. So we'll start from the top and work our way down. So if you're following along with me, then really try and feel this. What you first try and do is squeeze the buttock. So really squeeze the buttock through here. Make this nice and firm, okay? So squeeze here. And then with that squeeze, or after that squeeze, maintaining the contraction here, try and bring the thigh in. So activating the inside of the leg. So you're contracting here and then here. And then maintaining those contractions, contract the front of the thigh. As you do that, be careful of the knee that you don't hyperextend it or jam it back. So you have a contraction here, and now here, and now here. Then after that, try and create contraction at the back, so contracting the hamstrings. When you've done that, maintaining those contractions, try and contract the back of the lower leg, and then the outside. And then come down to the ankle, grip the toes into the floor slightly, lift the arch. So your foot arch, try and increase it. So you can see I'm just contracting that slightly. Activate the foot and contract that as well. So we've essentially created this continuous contraction all the way through the limb, and ask the individual to get those muscles to work a little bit harder and activate them. So as I said, you'll find that some of the knee osteoarthritis, they'll be weak in the hip, they may be weak in the ankle, and this will stimulate those muscles really well. Once you've contracted all through those muscles, make sure the individual understands how to fully relax them. It's an extremely important point. You may find certain individuals have too much tension, for example, around their buttocks. They're just contracting all the time, or their thighs. They're using it too much, and that may be causing some discomfort. So the understanding of relaxation is really important. So make that contraction one side, come back into samasthiti, and just feel as little contraction as possible. Maybe you do that a few times, for example, on one side and the other, lie down in Shavasana and really feel what it's like for those tissues to soften and relax, okay? Again, what you've done in that situation is you've created muscle tone and activity to stimulate them to wake up. You're trying to get this communication between the noggin, we call it the noggin in slang, but the brain or the head to the leg. Get that to stimulate, but you've not excessively loaded the joint. As soon as I bend the knee, if I, for example, for whatever reason, want to do a squatting movement, as soon as I start to flex, load increases. You're going to stress that knee out and cause irritation. I'll come back to that and squatting and lunging in a moment. So the fact that the leg is straight, it's still not going to be stressed. Okay, it's going to be minimally stressed. It's going to be a beneficial stress, and you may stimulate those tissues to get stronger. Certainly, you're going to stimulate the muscles to be more effective in stabilizing. Just be careful, just one word of warning with that movement. If the knee is, and you see it sometimes, the knee can be really unstable as they try and make those moves. For example, I mentioned they try and contract, they jam the knee back, and that may cause pain in the knee. Or as they try and activate the inside, it creates a bit of a twist in the knee. Make sure the knee essentially doesn't move its position. As you contract, make sure that stays pretty still. If you keep it still, it shouldn't cause any pain. If it does cause a bit of irritation to the knee, then just do less contraction. Try and activate it a little bit and see how you go with that. You should be able to do it in most people without causing any irritation, okay, if they do it correctly. Then I suggest from there, okay, and again, this is not necessarily a starting point, but something to move towards is balance. Balance is really important. In all my anatomy, every time I speak, I talk about balance, because every time I walk for a moment, a period of time, I have to balance on one leg, okay? As I bring that leg forward and back down. Now, if I'm weak in my core muscles and around the pelvis, and I walk and my hip drops, or I make that movement, and you see sometimes people with really bad knee issues, such as osteoarthritis, they make that movement as they walk. It's a strategy to try and minimize strain to the inside of the joint. If I do that, I actually put more load on the outside, but I digress slightly. If every time they are not stable, I mean, look at my knee as I move positions. My knee is moving, and that will cause irritation and friction within the joint. So our ability to walk correctly, maintain good balance, can help minimize stress to the knee. So when you look at the individual and bring their feet together, you want to test how well they can simply stand on one leg. If, as they do that, they've deviated, dropped, twisted, do it and lose their balance, it's something you need to work on. They should be able to at least stand for 30 seconds, maintaining that 1 foot off the ground, maintaining a really good position without a deviation. So this is not good for 30 seconds. This is a poor position. I should lift up, maintain it. That's a really important skill for them to develop. Because you're standing on one leg, of course, the load to the knee will increase and potentially, for some people, create a little bit of irritation if you do it too quickly. So it's something that I add in when I feel the individual is ready, but it's something I generally add in quite quickly because it's paramount that they actually get that skill back, okay? Now, from there, and I'll finish up with one of the last things I say, and I'll open up a few questions because we're starting to run out of time. Of course, you have to get the individual to bend their knee at some point. You can't avoid that for the rest of their life because they can't get into a car or drive the car. They can't get in and out of a chair, all these different things. So you have to start adding in some knee bend. But when you do, make sure that you've got those prerequisites, that the individual is starting to get some awareness. The muscles are starting to wake up. They've got some balance. And when you do add the knee bend in, I generally suggest you start adding it very slowly and incrementally, okay? So for example, if I do this much knee bend, there is, yes, more stress, but the further I go down, the stress increases. So the deeper the knee bend, the more the stress. So if I've got minimal stress standing up, that's a little bit, that's more, that's more, that's more. So start really slowly, add deeper knee bends in, and make sure that the movement of the knees is correct. So what we don't want to see, for example, you're starting to add the knee bend in. You're doing a simple squatting type movement. We don't want to see one knee starting to come in, buckle inwards, and create this abnormal stress. It indicates a weakness around the hip. Those knees we want to see tracking straight forward. If, for example, they come down, maybe they bend the knees 5 or 10 degrees, and they've got good alignment, they come down to 15, and then it buckles in, stay at 10. Maintain this good alignment, good position, okay? As they feel more comfortable with it over a period of time, then you go deeper. As soon as they lose control, stop, come back out. You've got to maintain the control of the joint every single time they use it. Every time they lose control, it's going to lead to irritation. Really, generally when it comes to osteoarthritis, we consider that deep squatting movements and lunges are contraindicated, but they're still needed. We need those in everyday life. So you've got to work out what the dose is for the individual. How much can you give them to maintain functionality of the joint without stressing it? And you'll have to gauge that by how they respond. So if, for example, they do the postures that you've given them and you've given them a few deeper knee bends after a period of time, and they feel fine during the class or the time that you're spending with them, but the next day the joint hurt, the joint is a bit burning and irritating, you've probably done too much. It's almost certainly. If the muscle, if they're aching around here, the back of the leg, around the hip, it's probably not a problem. You're probably not too concerned. The muscles are just getting stronger. But if they feel irritation in the joint, the general rule of thumb is you've done too much. So whatever you did, make sure you did it properly, or reduce it by 50 or 60, 75%, go back to it and start again. And when they can do 25 or 30% well, start adding 10, 15, 20% over the coming weeks. Bit by bit, more challenge and stimulus to the body to allow them to get that function back. Okay, so that was a whirlwind tour of osteoarthritis and perhaps how to manage it. I've run over a little bit of time, so I do apologize if I'm keeping you longer than I should have done. But I'm also very happy to take a few questions before we finish, particularly around the topics that we've just discussed. Sometimes at this stage, people will start telling me about their own knee problems, and sometimes it's really difficult to talk about specific problems that you may be having without understanding it fully and taking up a lot of time. So let's at least at this stage try and address the questions or any confusion about the topics that I've talked about so far. So as my teacher Raghu said yesterday about one of his teachers, that if there's no questions at the end of a talk, it means you've completely understood everything, or perhaps you've understood nothing. You got completely over your head and you're completely confused.
The session was really wonderful, sir. Thank you. Actually, I would like to share something which I underwent. Some few years back, I had a knee problem. And all of a sudden, I am a regular yoga practitioner, that is asana practitioner, okay? Beyond that, I haven't gone further on that. But when I did that, I felt so powerful, energetic, everything seemed to be going fine. All of a sudden, knee started paining. Right? Maybe something that I did, it created some tension around that area. I don't know. All of a sudden, whenever I started using my knee, there was some kind of tension, negative tension that was there. And my yoga teacher, he said, just to engage the kneecaps every time I start using the muscle, using the knee. Like if I'm seated for a while on the chair, and when I'm getting up, engage the kneecap and start moving. Similarly, even when working in the kitchen, so I'll be standing for a while in front of the counter and start moving. After a while, the knee will start paining. So he said, whenever you move the knee, just engage the kneecap and move. And don't do it like 100% engaging. Just engage to 80% of your comfort level. So that really helped. Within a couple of days, the problem vanished. So yeah, that came to my mind during your session. Thank you.
You're welcome. That's great. As we touched upon, sometimes those muscles around the knee, they can be less active with a knee issue. So trying to stimulate them a bit more can be really useful. As you kind of said, as your teacher said, not to necessarily over-engage them. We need to understand how much to switch them on, and also to understand how much we need to fully relax them to really get that stress out of them. Because often, as I said, there's too much tension is the problem as well. So getting that right balance, but it's a very good example. Thank you for sharing.
Hi, Rob.
Hi, Sakina. Nice to see you.
Yeah, good to see you too. Can you please explain what would be the major difference between osteoarthritis and osteoporosis?
Osteoarthritis, you can define as a loss of articular cartilage, so hyaline cartilage. Osteoporosis is essentially a reduction in bone quality, bone density.
Okay.
Yeah, so affecting the whole bone, osteoporosis, and osteoarthritis, just the joint surface.
Right. And what would go in a knee replacement? What actually happens in a knee replacement?
It's a great question. I can't show you an image. Essentially, and they can do it in different ways, but usually, most commonly involves essentially taking off. They will remove this part here and put like a cap, like a titanium cap through here and on the other side, and then a new plate, a titanium plate through here on the top of that tibia, and then join that all back together. And so essentially you've taken the articular cartilage away and the surface of the bone away and replace that with an artificial structure.
So you mean to say the meniscus is totally missing?
The meniscus is gone. Yeah.
Oh, okay.
So yeah, they remove that, and it's one of those operations which they've been done so much over the years, so they've got it down pretty well. Many people are happy with that type of replacement. In my personal experience, it's often being done too quickly. Often you can do lots of things to avoid that. As I said, I've seen countless of patients who've come to me saying the doctor says I need a knee replacement, and they've done some simple things and they've been very happy with the functionality that they've got back. And it's really following along the lines that I said. It's not necessarily rocket science. You don't need any magic wand or magic fingers. If you follow the lines along the lines that I said, you'll get often a great deal of success in improving someone's symptoms with osteoarthritis and at least delaying the need for a replacement, which is often people, want to get. Thank you, Rob. My pleasure.
There is a question in the chat. I would also like to know the answer. What is the engagement? What does it mean? How do you convey that to other people? How to engage the kneecap?
I'm sorry, I don't understand the question. Who's saying that? Who said that?
Jyoti.
Hi, Jyoti. What do you mean by that, Jyoti?
No, you said engage the hip and the thigh muscle. Not many understand because people who come with osteoarthritis are older people. So are there any trigger points we can tell them just press and then those muscles engage, something like that? Now, when I say engage, they just don't understand what I'm trying to tell, even if I show them. So how can I bring that?
I would get them, depends on where you are and how you work, but if it was me, I would just poke a finger into the muscles I want to get activated. Or obviously in some situations, it's not appropriate to use a hand contact. So I would ask them to place their hands. So place their hands on their buttocks and feel that contraction. Place the hands on the thighs and feel that contraction. And that can help bring or restore or build a better kind of understanding of the brain and what it wants to do.
Okay. There are no trigger points where I can say, so I'm sorry, just say, if I press like this, I'm just showing my knee. Will that help to engage something? Some just points where I can just, if not me, ask them to do that.
And when you say trigger points, are you talking more about massage or?
No, not massage. I would say, I don't know how to tell you now. Now, if I press somewhere near the knee, suddenly your quadriceps tighten. Is there something like that which I can explain to them?
Not that I'm aware of, no.
No? Okay. Okay. No. All right.
Good evening, sir. Could you please explain about Baker's cyst?
Sure. Baker's cyst is essentially, it's seen very commonly in knee osteoarthritis and meniscus tears. So meniscus tears can be traumatic or degenerative. So you can have a situation, a sports person, for example, moves in a certain direction and their knee suddenly deviates in it and slides across each other, and that can tear the meniscus. Or you can have a degenerative meniscus where there's constant irritation and the tissue starts to break down. In both situations, you can get a Baker's cyst, but essentially it's around the joint. I've got an animation of this, which I couldn't find off this quickly, but essentially the synovial fluid escapes out of the joint into a bursa at the back of the knee. There's a communication happens between the joint and the synovial fluid and a bursa. A bursa is a fluid-filled sac, which you find around joints and around tendons in particular, which helps reduce friction. It's a bit like a cushion. So as we move our joints, tendons can rub against bones, okay? And that can irritate the tendons. So we put bursa around that like a cushion to protect them. With a Baker's cyst is essentially an enlarged bursa, and it's filled with synovial fluid. Now, you can find that if you can correct the problem, even with a degenerative meniscus tear or osteoarthritis or a traumatic meniscus tear, if you can improve the situation, the Baker's cyst will decrease in size, okay? In some cases, you can improve the knee and the Baker's cyst won't change at all. In some cases, the Baker's cyst can get so big, it can start pressing into one of the main arteries down the back of the leg and start affecting circulation into the lower leg and the foot. Generally, trying to answer your question fully, You can have that surgically removed, but generally they just come back. So it's generally not worth being surgically operated unless they are pressing into the artery and creating circulatory problems, or in some situations they start pressing into the nerve. And that can lead to numbness in the leg. Quite a rare cause of it, but it can be possible. If the Baker cyst is really big, I say not that big, but big, then they can actually burst. They can actually pop, and they're quite painful and red and swollen if they do. But again, them bursting is very rare. You just may need to be a little bit careful of certain movements. For example, sitting in Vajrasana. Okay, so sitting in like a hero pose, the pressure, as we come through here, that can sometimes create a bit of irritation for some people. They may conversely feel a bit of irritation where the leg is straight, depending on what's going on. My general feeling is you get the knee moving better, the muscles around the knee working better, more function from the knee, less irritation, and then see what happens with the Baker cyst. You may find the Baker cyst naturally comes down rather than just trying to target the cyst itself. Make sense?
Thank you so much, sir. I also have one more question. How serious is the case of anterior and posterior meniscus tear? Is that in the extreme cases?
It depends. There can be different type of tears. Like if I've got a tear, if I say I've got a tear in my jumper, that could extend all the way down, or it could be just a little bit. So it depends on the degree of the tear. There's different categories of tears. It varies a lot. Someone could have a meniscus tear and have very little issues. Another person could have a meniscus tear and have terrible instability of the knee. Every time they move, their knee buckles because the meniscus also stabilizes the knee. So I've torn my own meniscus. And I managed it conservatively. I didn't have any surgery. I know lots of people who can manage it conservatively. Some people it's extremely problematic. So it depends on a case-by-case basis. But generally, if you can, if you do the right things, you can avoid surgery generally. So I wouldn't say it's too serious.
Not the solution. Surgery is not the solution, no, sir. I just wanted your suggestion.
It can be. I wouldn't want to say, because I would want to know a bit more about the individual. Like I said, if every time they're walking, their knee is popping and they've got no stability and they've tried physiotherapy or yoga therapy to get stability back and they just can't get it, I would probably suggest maybe it's better you get surgery because everything else isn't working and you're more likely to cause a bigger problem. But when it comes to meniscus tears and surgery, once you've torn the meniscus, you've got greater risk of osteoarthritis. Okay, the joint won't be 100% right again. But even if you do a surgical repair or intervention on it, your risk of osteoarthritis is still pretty much the same. So the only situation where it's quite good, or some people would like to get the meniscus surgery, is if they're a sports person, they want to get back to playing sports very quickly, especially a professional athlete. They've got a short career. If they're out for 12 months or 6 months, they want to get back to playing as quickly as possible. So in that situation, because of money and their desire to get back, they go for the surgical route or option.
Thank you so much, sir. Very informative.
Was there any more questions before we finish?
Dr. Rob, I had one more question on this meniscus, if you have the time. Otherwise, I can keep it. I have discussed this before with you, that I have a student who has this meniscus tear quite often. Okay. And now he has decided I'm not going in for surgery. Earlier he's gone for surgery. Are there any movements that I need to take care of, or he has to take care of, who has this perpetual meniscus tear problem? He has bow legs. Okay. Okay. Yeah.
It depends again a little bit where the meniscus is torn and how it's torn.
Inside. Okay.
Because as we bend the knee, different parts of the surfaces will come into contact with each other and create different stresses. So some people with a meniscus tear, they may get more pain as they straighten the leg towards a more straightened position, whereas other people get more pain towards flexion. Whatever movement it is, it doesn't really matter. Just be really careful of those movements where they feel discomfort. Generally, I would advise you don't push the knee or force the knee or ask them to do too much in that discomfort or that painful range. One of the most important things is to make sure, because often there's a loss of stability of the knee can be quite weak, and therefore the risk of re-injury is quite high. The way that the brain communicates to the knee, again, is diminished. So you've got to do generally lots of things to improve control. So balance skills, quality of movement. As we looked at earlier, just balancing on one leg, balancing with the eyes closed, coming up onto the toes. Coming up onto the toes on one foot. So balancing on one foot and coming up and down. Lots of balance skills. In that fashion with the legs straight, and then progress to really good control of other movements, such as lunging type movements or squatting type movements. If they can control the knee is protected and they're not likely to create a secondary injury.
Oh, that's lovely. Thank you so much.
My pleasure. Okay, so thank you so much. I will leave it there now. I will make the recording available. I will send you a link to the recording should you want to go back and see anything, or if you want to share it with anyone. As you're aware, I do have 2 courses on the knee on the website. If you are interested to learn more about the knee, about other conditions, where we go into the anatomy and understanding and therapy of different conditions, they are available. Do check those out. And stay tuned for another masterclass coming up soon. So thank you so much for coming. Really appreciate your attendance and your enthusiasm for this topic.
Thank you.
Thank you.
Thank you.